All right, let's go ahead and get started. Welcome to today's webinar, Meniscus Tears, a comprehensive review of the anatomy, biomechanics, and surgical treatments. This webinar is hosted by Medical and Life Care Consulting Services, case management and nurse consulting firm, headquartered in Massachusetts. I'm excited you've joined us for this presentation. My name is Gigi Liggins, and I'm the moderator for today's webinar. This webinar is anticipated to be about 50 minutes with an additional 10 minutes provided for questions and answers. Participant audio will be on mute throughout the webinar, and we ask that questions are submitted using the question and answer feature within the Zoom webinar dashboard. Post-webinar, we will share a link where you can access an on-demand replay, along with a link to a short survey. Please take a moment to complete the survey. Your feedback is valuable and it helps us in planning our educational resources. We're excited to host today's webinar, and I look forward to an opportunity to partner with you. To kick it off, I'd like to introduce our host, Cindy Fleury. Cindy Fleury graduated from St. Vincent's Nursing School in 1986. She went on to start her career as a nurse in acute care setting and spent the first 7 years caring for medical and surgical patients. From there, she went on to care for patients in their homes, managing and overseeing their care. And in 1999, she ventured into the workman's comp arena, initially as a utilization review nurse, quickly switching to case management, which has been her passion ever since. Since she has worked both in the field as well as in an office setting, overseeing and managing workers' comp patients for a physiatry office. She's been working at Medical and Life Care Consulting since 2016 and has returned to the field of case management. She enjoys being involved in the patient's care right from the start and seeing them through to full recovery. Outside of work, she enjoys cooking, gardening, hiking, and spending time with her family and friends. She is married to her husband of 37 years and has 2 grown children and 2 beautiful grandchildren. At this time, I'll pass it to Cindy Fleury. And Dr. McKeon, can you go on to the next slide for us?
Oh, sure.
Thank you, Gigi. Now, before we dive into this session, I'd like to share a little bit about the Injury Insight program. Injury Insight, now its 4th year, is a 4-part webinar series designed to educate claims professionals, HR resource professionals, and case managers on the rehabilitation and recovery process of injuries, illnesses, diagnoses, and treatment, both common and uncommon, within workers' compensation. The program allows claims professionals and industry stakeholders to have direct access to medical specialists to help you better understand the diagnosis, the road to recovery, and potential obstacles, and answer your toughest questions. If you've missed any of our prior sessions, you can access them online at www.medicalandlifecare.com or by visiting our YouTube channel. For this year's 2nd session, Meniscal Tears, a comprehensive review of the anatomy, biomechanics, and surgical treatments, we're pleased to have Dr. Brian McKeon. Dr. McKeon is the orthopedic consultant and emeritus medical officer for the Boston Celtics. He also serves as an assistant clinical professor of orthopedic surgery at Tufts University School of Medicine. He is an active member of multiple academic societies, including the American Academy of Orthopedic Surgeons, American Orthopedic Society for Sports Medicine, Arthroscopic, Association of North America, and the NBA Team Physicians Society. Dr. McKeon currently participates in clinical trials and funded research studies related to articular, cartilage, synovial inflammation, stem cell therapies, and artificial meniscal implants. His primary clinical interests lie in sports medicine and the treatment of sports-related injuries, with an emphasis on performing minimally invasive surgery on shoulders, knees, and elbows. At this time, I'd like to hand it over to Dr. McKeon.
Thank you so much, and thank you, ladies. To the course participants, I tortured these ladies the last couple of days. For some reason, tough internet access or something. So I'm down in Florida, and so thank you so much, ladies, for really helping me get all this up and running. I have a lot of insight, and I think of my job is so unique. I'm constantly thinking how I can get better every day with everything, and this is a surgery that I performed. I've videoed pretty much all my surgeries from the very beginning. I think I have 30,000 clinical videos that I've compiled and try to organize. But this is the case I did. In fact, I remember her name. It was like early 2001 or two. And the upper picture shows me, it's a meniscus tear. That's a thigh bone and shin bone above it right here, thigh bone, shin bone, and that's the meniscus. And it's torn. And that's what we call radial tear. That's the configuration. We'll get all to this in a second. But anyway, I cleaned it out, right? I basically got rid of the mechanical unstable portion and did not know what I was doing at the time. And these are the cases that we've all familiar with. Like, geez, why'd I have it scoped? Geez, I should have gone to your doctor. Geez, man, I'm worse now. I shouldn't have had it scoped. Geez, man, or my uncle had it scoped and he ran Mount Washington the next day. So there's just so much misinformation, so much misunderstanding. And I want to break this down today for you to make it so clear. And I think if you understand like the way my brain works on this, that I think you'll appreciate more than most orthopedic surgeons because our whole life now is prior authorizations, getting approvals, and and you learn when we get 10 calls every night about denied for meniscus MRIs or surgeries. It does make you better. So I'm trying to take positive energy out of that, and there's so much misinformation, and so rightfully we deserve to get all these questions asked, right? And so this particular woman, this was her x-ray here. And then literally like 7, 8 months later, went to bone on bone. And this is legit. And so when you have that happen quickly, when you go to bone on bone quickly, 7, 8, 9 months, 2 years even, it is very painful. When you go bone because you had 2 scopes in college, maybe you played 1 year professional ball in Europe, whatever, and you're 55, 60, you go to bone on bone, or it's much more manageable. So it's sort of how you went to bone on bone is really, really critical. And so in the beginning, 1994, this was a big transformative article for me personally. This was like, okay, we can grow articular cartilage. Because when I look at a knee or any weight bearing joint, I always think articular cartilage, the shiny white stuff at the end of the bone. I always thought that's the most critical thing, and everything else around is just there to support it, ligaments, meniscus, etc. And so much that I became fascinated by it early on and got involved in trials. And I even went to Gothenburg, Sweden, where that's where they came up with the first article, growing articular cartilage and transplanting it. I thought maybe we were going to cure arthritis because that's the goal. That is the ultimate goal. This is our goal, right? We want to, we have this beautiful, shiny, gorgeous articular cartilage. And once it turns to this, it can become a battle. It can be very, a lot of lameness and issues, okay? And which you all know about. And this cartilage here is about, I tell patients, 6 times Zamboni ice. I think the NHL finals are going on. So this stuff is so smooth, but it's got no blood supply, no nerve supply, no vascular supply. It's a very complex macromolecular organization on a cellular level. And I thought going to Sweden, I'm going to figure this out, come home and, start transplanting, and curing people. That wasn't the case. Okay. I spent a few months there. And the bigger issue is that we all know this, right? Doctors are putting in replacements younger and younger. I mean, it's just amazing. The numbers are staggering. And, this is about meniscus, but this is what we're trying to avoid, and the analogy would be the hip, the labrum, right? And I would think the hip guys, the hip doctors are really interesting because, we started knee arthroscopies back in the 80s. Hip arthroscopy really didn't gain a lot of traction until about 15 years ago, not too long. And they are so far ahead of us already. They've leapfrogged past us about taking the time and the effort to really reconstruct. So it's not just a scope; it's more than that, and that's why there's a lot of misinformation. And the biggest thing is for me is understanding anatomy. When I was in med school, I literally, like my other co-medical students that shared the cadaver with me, would come down, pull the draw out, and I'd be in there, I'd be like, "Good morning." I spent so much time in that darn thing, and I just fell in love with the human anatomy. And that's always been my savior because, what does it really do? What's the form and the function of this structure? And that will give you a concept and understand it better. The most important thing, test question: what's the most important function of the meniscus? It is a load bearing, load transmission, right? It takes these forces You know, when you're single weight bearing going on to one leg, I mean, it could be 10, 15 times your body weight. It's unbelievable. A lot of other factors we'll get into, but it provides stability, right? Because the end of the bones are convex and concave. So there's really not much stability. So you need the ligaments and you need the meniscus. And a lot of data and evidence now showing the lubrication and shock absorption. It's got many, many factors. This is a blown up model picture. So this is the load, right? So this is the bone, the white, cartilage is blue, the space is yellow. So the meniscus are these black structures. So this is like a Big Mac or a sandwich. So when you walk on this every day, right, there's a lot of activity going on in your meniscus. It's like a gasket, right? In fact, I just cut out a sponge. Literally, when they introduced me, I came up with this idea. So, you know, when you walk on a meniscus, you know, just like a sponge, it spreads out like a sponge, and then it so it goes in from a solid phase to like a water phase, right? And so it literally is very active, and so it's phenomenal what it can do. And again, the meniscus has its own issues with blood supply. We'll get into, but if you look at the forces, the red's the forces, the way the meniscus is oriented, okay, it's oblique, right? It's not like flat, not like flat here. So it's oblique. So if you have a force coming this way, okay, so you know every force has an equal and opposite force, right? So this main force going down, okay, and right and responding back here is the ground pushing back up. So you know the thigh bone is driving into the meniscus, and the ground is pushing back up to offer the stability. And then there's a force going out this way, okay, and what handles that force? That's all meniscus, right? And that's the whole point. Okay, that's meniscus extrusion, which you've heard about. So the ability for the meniscus to handle all that is just critical. And when you lose the meniscus, the forces just get totally, you know, just basically focused right on one little area. So you get a point overload. You know, and you can't distribute the forces, and you get breakdown. These are all basic concepts, and it's going to be more illuminating to you in a little bit. But we've known forever. You know, 1948 was the big article, Fairbanks, that he said, look, you know, you take out the meniscus, you know, look out, you're gonna have trouble. And that's very much the case today, and we still have not even come close to kind of figuring this out. So load transmission, and these are the forces I was talking about. And it's amazing with the knee straight extended. Okay, so if you're just walking like with your legs straight or just standing in church, you know, whatever, right? The meniscus handles about half the weight. But when you bend and flex, like bowling or you're getting out of your car or whatever, I mean, it's up to 90% of the load. Meniscus is, you know, taking massive loads, massive. Of course, many of you may know the femur rolls back, so it's very dynamic. The knee's not a hinge. So, you know, when you hear these, you know, you take 100 MRIs in people over 80, you know, you can get 50% of people are torn without symptoms. And so it makes sense because of the loads and forces that are put on this. But the most important test question for the residents and things to understand what the meniscus does and why I'm going to give an argument, which I'm going to try to build here, is these circumferential fibers. So the meniscus, this is an illustration of it. These longitudinal fibers, they're collagen. These are bands. These are tension bands in the meniscus. Very powerful. All right. And these are analogous to a wine barrel. And so when you fill a wine barrel up, you know, if you don't have these metal bands, these forces will blow out the wine, right? The wine's too heavy. It'll blow out the sidewall of this case, right, of the barrel. So these offer these what we call hoop stresses. So those circumferential fibers are hoop stresses. So when you walk on a knee, okay, you know some forces are handled by the ground, and these forces are called hoop stresses, and they're handled by the longitudinal fibers. Okay, and so it's such an unbelievable mechanism. So when you walk, your meniscus does pinch out a little bit or extrudes, and then when you go to the other knee, it bounces back, right? So it's very, very dynamic. You can see this in ultrasound. Thin people, you can even feel it, right? And so, because this big word of meniscus extrusion is, you know, one of the hot topics we're going to get into, and it's based on these mechanics. So if you're lying in an MRI, you know, you're not putting weight on it. The meniscus should not be out of the joint, right? It should be all lined up just like this, okay? And so, and then of course, stability is a big thing, right? Stability. And so we all know there's a big relationship with no ACL. You know, if your ACL is gone, the meniscus becomes the, you know, basically the wedge underneath the a telephone pole truck, right? The wedge under the tire. So it's a stopgap mechanism, right? It's a backup. This model, this diagram up here shows you with the anterior translation, the meniscus eventually gives up. And that's what's called a ramp lesion. You may have heard that word, ramp, another popular, word, but all these are the same concept. Everybody's got a job to do. And, if you have no ACL, it's going to really increase the risk of meniscus overload, and more than others based on a lot of anatomy. This video below shows, me just moving the knee and boom, flips up the bucket handle tear because the ACL's out. And this just shows, again, another illustration of it. Nice cadaver view here. So you've heard of the word SONK. SONK is, maybe you have. I've had one case in my life, and way back when, and was a woman from Scituate, I remember her name and everything, where I scoped her knee. Hey, you're going to do great. No big deal. No arthritis, very little. And her knee went on a journey and basically died. SONK stands for Osteonecrosis. And we didn't know what it was for many, many years. It's called spontaneous osteoporosis of the knee, SONK. And all it means is you scoped the knee and it just gave up. It didn't do it. It did worse. And these are things we all hear, right? Patients fall, surgeon didn't know what he was doing. My physical therapist bent it too much. Everybody's kind of like looking for a reason why. And, it was a mystery for a long time. But, I figured, but we've all figured this out and understand that the knee was on its way toward the meniscus. And, and the doctor went in and just kind of cleaned it up, see how you do. And, so those are the cases that people just started jumping on, the Journal of the New York Times and all these articles about to show you. But if you look at this MRI, the bone's all lit up. That's the white. That means it's overloaded. This is dead bone here. This knee's in trouble. It's called SONK. Some of you may have heard of it. But if you notice the meniscus, this black thing, it's extruded, right? It's not in the joint anymore. See, the lateral meniscus is lined up. So this whole concept of extrusion, why did it extrude? Because it let go, it tore. And, myself included, way back when, didn't understand the whole concept of a meniscus that's extruded. If you go in there and just clean it up, see how you do, those patients are going to do lousy. So in life, we talk about don't do a scope because they all do terrible. That's ridiculous. We should, same with COVID. Why should everybody be hidden in a bunker somewhere? I think it should have been people that are sick, asthma, and we should have basically learned how to, classify people, subtype them. Same with meniscus. There's certain tears that look out that could become a big problem. And we've done a terrible job relaying this to you, this messaging to you and to the insurance companies. But what happened was this article came out when I was just out in practice. I just started in 2000 and I came out and I remember New England Journal of Medicine, big deal. And I said, that can't be true, right? They took, I think it was like 100 patients and 50. They took them all to the OR. 50 they did surgery on, the other 50 they didn't. They did incisions, did not do any surgery. And then they had all this, blinded follow-up type one study, wonderful job, for the most part. And bottom line, they found no difference in these patients at 2, 3 years, 4 or 5 years follow-up. So in other words, the scope was worthless. And man, did the media and insurance companies get a hold of this, right? There was a follow-up study, and this has been collaborated and confirmed. A lot of Scandinavian countries saying, look, you take 500 people with meniscus tears and 250 you fake scope, the other 250 you do scope. No one's better. There's no difference. So why are you doing the arthroscopy? And and those are compelling arguments, right? And this is where it got really interesting. And I couldn't find this other article, but this is 13 and 16 in the New England Journal, the New York Times. And I remember these articles, right? But I remember there was one in 07 saying, hey, why are we doing scopes? And then back in 13, after these articles came out, they said, look, the surgery doesn't do much. And then in 16, why are we still doing it? This is malpractice. Like spine fusions. We went through this for spine fusions as well. So this is the public opinion, right? And this is we did a bad job as orthopedic surgeons and scientists and biomechanics professionals to really relay and understand this and get the messaging right. And we still haven't. And that's why it's a big black box. No one really knows what the hell is going on because there's just not proper messaging. And that's what I want to kind of, hopefully, I'm on the pathway to clear this up. And this was really interesting. These were the follow-ups to the patients that were in the Moseley trial. So this guy went back. So basically what this doctor was saying, look, he had this unbelievable article 15 years prior. This is 2017. And so this guy's saying, look, it was a big article, and it was the one best article of the year, whatever. And the doctor, researcher saying, look, did it have an impact? Did it do anything? Did doctors listen? Did it have any type of influence? And the answer was no, it did not. And I think that's why the insurance companies are doubling down, denying everything. Like, I don't blame them on certain aspects. And we'll get more into that, right? And, with medicine and all these great research engines now, you can find an article to support anything you want, right? But one thing we do know for sure, right? The meniscus is critical. And what I was trying to tell you, and I didn't finish it, when I went to Sweden, I thought it was all cartilage, cartilage, cartilage. I did cartilage trials and enrolled in FDA guided trials. And then I realized, my Lord, if the meniscus, especially if you're a pro athlete, you can take out all your meniscus, all of it, and you can get signed for $42 million a year for 2 years. But if you have no cartilage, shiny stuff, your career's over. So maybe I got misguided myself. Like, okay, I'm like, meniscus is not important. You can still play without a meniscus, but you can't play without cartilage. But the knee can't survive without a meniscus. It's very, very important. And that's my own personal journey. And that would, a lot of you guys know all this stuff, and I'm exaggerating a little bit, but it takes studies like this to prove everything in medicine, right? This is a 40-year follow-up published a while back, where it says, look, if you take your whole meniscus out, right, we've been able to follow these people for 40 years. And man, that's just a major, you take out the meniscus, like this shows me removing a bucket handle. This is 15 years ago, right? I know that because I don't use that clamp anymore. So, but if you take a meniscus out 15 years ago, you're going to have a problem. Guy's going to go on, or gal, on the arthritis. Now, there's other variables, and, I always tell patients, like, running doesn't cause arthritis, or pounding on your knee, or heavy athletics, pounding. But without a meniscus, it can cause arthritis. And so the end of the day is, people have these expectations, but this is a well-designed study, long-term follow-up, right? But the pendulum swinging. So my point is that, yeah, you're right. We shouldn't just be scoping people, right? But what we need to do is repairing people. Okay, so it's not like, okay, we just got to go non-operative, Brian, and put platelets in there and pray. There's some validity to that, but there's no question. Instead of just scoping people, we have to repair them. So, and many doctors, they do 10, 12 and line them up the day, community doctors mostly. And I've been there to some level, but, that's all been such a major mind change for me, in the last 15, 10, 12, 15 years. It's, those days are over, man. For me, you got to do everything you can. And the trends are starting to take hold, right? We're starting to realize that we got to repair these, and not unlike a team. I was the chief medical officer for a team, pro team. It was wonderful. And there's a lot of levels here, right? We all have these in certain relationships and, in our hierarchies at our jobs, right? There's many variables. Like, many of us can be like, why am I dealing with all these people? I can just handle this. The point is that you need many people involved, multi-levels. And that's the same thing with meniscus. It's just something I came up with. You can't just be, you got a tear. Let's just see how you do. Well, so much more, right? Where it is, arthritis, lawyers, you guys know that, right? Ligaments, the status of ligaments. So it's much more complex than that. We'll just scope it and see how you do. These variables got to come in your brain every single time you see a patient. Okay, every single time, and the whole limb. But meniscectomy will always still be the most common. Why? Because it's easy. I tell patients, like, the surgery is the easiest part, right? It really is straightforward, right? We got such amazing optics and cameras and equipment. It's not hard, right? And so this is one from several years ago, okay? And it's easy to perform, low complications. The guy or gal can get on a bike, get back to work quickly, right? All these advantages for the short term, right? And if you look at meniscectomy versus repair, okay, I have orthopedic surgeons tell me, like, Brian, why the heck am I going to repair all these things? Because, like, look, it's so hard to take care of these people when you fix them, and damn, they are right, right? Because the short-term revision rates are higher, right? You can return to play and get your life back. I mean, it's 4 weeks and 8 months. I mean, it's a big difference, right? Muslims, right? I did a Muslim recently, did one of my crazy repairs, all crazy in the sense of, like, I go through every possible method and pathway to fix these meniscus, but you can't kneel on it, right? They play 5 times a day. And so I'm not kidding. Like, you have to put restrictions on people. And so it's a very difficult, you got to really communicate with people. You got to show videos, spend a lot of time to help them understand that. We know a lot of the principles of repair based on vascularity. And so this was an inflamed knee that I was scoping with a tear. And it's just It's amazing. The human body is amazing, right? You learn so much, but you can really see where the line ends, right? And so, that's called, so if it tears right in the middle of this vascularity, that's called a red tear. If it tears right here, that's called a red-white, because there's blood on one side and white on the other. And if it tears here, it's called a white tear. You've heard these words maybe. And this is all based on a gold trichrome stain. It's probably the most famous, least lower extremity knee picture in orthopedics, right? In fact, Jason, my PA, this is from a guy at HSS. Jason, my PA, has a signed picture of this. I got all these athletes. Jason's got the meniscus signed from the researcher. It's kind of funny. This is a radial tear right here. And this is where we got to get into and talk with you guys. These are evil tears, okay? A radial tear is evil because that can transect the whole meniscus, right? You can just see the pathway it's going. So when you talk about tears, it's like saying you have a car. You have to really define it along other things, alignment and BMI and many other factors. And we're going to get into some in a second. This is actually a radial tear right here, okay? One of my patients. And so it's almost like you took a scissors and just snipped it. And that is going through the longitudinal fibers. Very, very disruptive. And a whole textbook in of itself. It's, so once you have radial tears, that can go. So here's an example. I had a doctor's son recently, not that long ago. He, was wrestling, I believe, in college. And he just had a tear. I probably should have showed it. I mean, from here to here. I mean, small. Like, you'd almost be like, most people wouldn't even gotten an MRI, but, he had an injury, right? And so that's the time to go. Because I can do a little snip. That kid's going to do unbelievable, right? We see how he does, wait it out, limited his play. That thing zips like a favorite shirt in high school. That zips and that completes through the whole meniscus. It's over. That's a complete separation, right? And so a radial tear that completes right here. Okay, your brain thinks you have no meniscus. Your knee thinks you have no meniscus. That's the equivalent of no meniscus. And and this is sort of what a normal meniscus looks like, right? It moves and slides. It's very dynamic. And if you look here, here's a tear, right? That meniscus is just leaving. So even though that meniscus is there, that looks the same as that. That meniscus is staying in the party. That guy's helping. This meniscus is like, see you later. And so you don't see the radial tear because it's coming at you, but that's what's happening. So even though people go to me, doc, hey, how much of my meniscus is torn, right? And so I might as well show you this now. This is just 2 water bottles and a sponge. That's what a meniscus does, right? And a meniscus should be lined up, okay? Should be lined up perfectly with these are the bones, the balls of water. Meniscus should be lined up perfectly with the side. And when you walk, it should squeeze out a little bit. It should bounce back. That's what that video is showing, right? But people ask me, how much of my meniscus is torn? If I just took a scissor and I went snip, all I did. So how much is that? 1%, guys? Right? This meniscus is cooked. It's over. That's the biomechanical equivalent of having no meniscus at all. So if I walk on this thing, it just sprays out. See? And even if it bounces back, sometimes you don't even see the things. MRIs are normal because you catch it early. So, an understanding of that is so critical, right? So that's this meniscus extrusion. This is a case. This woman had there's a spine rep down in Rhode Island. She had a bunch of 3 surgeries, I believe, even had an old surgery, which is a chondral graft to the inside of her knee. She was doing lousy and came to me through a friend and of hers who I know. And she was recommended to have a total knee replacement. And this is what's happening in the community. Doctors are finally understanding this. But I will tell you that if you understand 60% of my presentation, and I'm serious, I think you'll know more than 80% of orthopedic surgeons. Because, it's not just that meniscus is torn, right? Because it's extruded. So here's her x-ray. It's not a bad x-ray. Now she's got some morphological change, dysplasia from her, but that's not bone on bone, right? And there's doctors that are getting smart saying, I ain't doing all this. Just get a total because you've had 3 scopes. Total's life altering to me, right? A knee's not a hinge. The way a knee works, the elbow's a hinge. It's all an elbow does. It's a hinge. It's called 1 degree of freedom. The knee does a spin, a roll, a slide. It's got 6 degrees of freedom. So, and this is me speaking generally. So when you do a total knee, you make it a hinge. So if you're a lineman, if you're a pipe fitter, if you're a steel guy, working at General Electric, and you're getting off the ladder, right? You're landing on your heel. you don't get that feedback. You don't have your ligaments anymore. So a total knee is just not going to perform in my mind. Right. And so, that's the people that are really frustrated. Young people who have even a well done total knee, the x ray looks great. They struggle with a total knee. Many of you may know that. Right. And so if you sit and really talk with them, and what happens is the total joint guy says, hey, your x ray looks perfect. I don't know what to tell you. Go see McKeon. Right. And basically, it's just not working for them because their brain's not ready for a hinge, the way I look at it. So this meniscus is extruded. Okay. So she's lying down an MRI. That meniscus should not, it should be lined up. So it's out. And why is it out? Like, I don't even need any other images. And of course, you look at all of them. But that tells me this thing is torn. It has to be for this to be extruded. Right. And so it's a non weight bearing MRI. That meniscus is no good. This is your pre-op. So, I told her, look, it's going to be 8 months. And this is, what my PA calls a thankless job. And this is another view of her MRI. If you look here, guys, this is actually, sometimes you get lucky in the axillary views, you can really see it. There's the snip right there. That's a scissor snip. Right? So that's a deep radial tear. So that her knee thinks she has zero meniscus and it's starting to pay the price. So some doctor in Rhode Island cleaned it up a little bit and then put an Oates plug in. I mean, that's not going to work. There's no chance. And when you look at the knee here, these videos over time of surgery, it's not awful, right? We're seeing white, right? That's the first thing you always want to see. You want to see articular cartilage. There's the plug. See the Oates plug? That's an Oates plug right there. So it's hanging in there. She only had it 9-10 months prior to me going in. So, but it would have broke down. She would have broke down and gone bone on bone. But she was in pain, a lot of pain. And it was either total knee or do what I had to do, okay, which is a meniscus centralization. So when you see wear on the tibia, that's the thigh bone, right? The tibia, okay, that's a trouble. That's a battle, all right? So I did something called meniscus centralization, or I call it a meniscus lift, where I lift the meniscus back into the joint. This is me starting to sew it, right? And these take forever to clean this up. If I went in there and said, look, I cleaned it up some more, let's see how you do. I mean, that takes minutes. I mean, this thing took me 2.5 hours because it's like sewing wet tissue paper. And so, it's a battle, but you get in there, this is fiber wire suture, and you do a lot of freehand stuff and you try to recreate the anatomy, right? Here's your blood supply, right? And the visual can be tough, right? And I basically put an anchor. And I always tell people, I asked my PA Jason, I go, hey, how's Miss Swanson doing? I'm making this up, and he's, I never get like, oh, great. Because, I tell most patients, and I did this surgery in 2 of my partners, by the way. So I made sure my clinic days didn't match up with them for about 5 months. Because that's what I tell people. I said, for about 5 months, you're not going to like me. And, you get the voodoo dolls, people trying to stab you because, you got to hold them down, right? They're frustrated. I get an unloader brace, right, in patients post-op. But what's amazing, okay, because the only way to do this is to do a centralization, right? The only way I don't know why these aren't lined up, sorry. But I got the meniscus back. I got it under the party. I got it back under. Now, all that suture you put in is fiber wire. It's non-absorbable. So on an MRI, that's going to look like a line, right? It's not going to look, the radiologists don't know what they're looking at, right? But I have a second look that I'm about to show you because she developed so much scar. Her kneecap gets stuck. The biggest issue with all of these patients that have an extended recovery, total knee, ACL, whatever, is patellofemoral stuff. It gets stuck, right? Because it's not mobilized enough. So I went back in, and I would it was amazing. I didn't get into her videos with it at the time of surgery. Of course, I took like 55 of them. But this is me when I'm back in. She had failed a little bit, but this is reconstituted. She has now an attachment. The meniscus is no longer separated. And, and look, I have 2-year follow-up now. I think she's a 1.5 years out, maybe 2 years, and she's doing great. Not the expectations she wants, but like she doesn't have a total knee, and she's only 49 or something. So, that's a big victory. But the expectations are challenging because she still have arthritis, right? Still have arthritis. When you look at, when you ask yourself, Brian, well, all the stuff you're doing, is it worth it? This is what doctors would tell me. Well, I take it out, it takes me 8 minutes. And you're in there for hours punching and fighting a meniscus. And I'm like, true. So they were like, is it worth it? And, and this is where you look at some of the long-term data and follow-up. We know if you take somebody's meniscus out, there's other variables like alignment, et cetera, that they're going to have troubles long-term. Okay, they're just going to. All right, not every one of them, but radiographically, at least everybody will. Right, but then you look at repairs. Even our repair techniques at 10-year follow-up. Right, the longer you follow up with repairs, all these studies they show, some failure rate. Okay, they can fail later in life, later, in the spectrum of the treatment. So we don't have great answers, and I have more points at the end. And I've done everything, right? This is a girl had woman. She's a young kid, 21, had 3 ACLs, didn't work, right? And so I broke her leg, realigned her, waited 8 months, and then transplanted a meniscus on her. Okay, that's a meniscus transplant, right? I got her alignment restored. Okay. She's actually doing dynamite, but she's 21. I hope she is. Right. And by the way, I also did a chondral graft. I don't know why this should be a video. Yeah, you'll see it right here. Oh, um, uh, all right. Oh, shoot, Brian. Well,
Just hold tight momentarily, folks, while the PowerPoint reloads.
sorry, guys. Sorry. This is a nice thing. It's a nice thing I don't get yelled at because you guys keep. I apologize. And so she's actually doing great. I restored her, restored her anatomy to the best I could. And so, but boy, that could all been avoided initially by meniscus, right? Some people need the ACL meniscus, their combination more than others. And I apologize about this, guys. This has been my last couple of days here. Um, and so I've also some guys, and mostly plumbers are like, Doc, can't you just put a shim in there? What's going on, right? So I've, not because they've asked me to, but I've done trials on metal. I've tried to put metal in a joint. Okay, I've done trials on a plastic meniscus. I really thought that would be the answer, and it did work, but they break. So there's no longevity, and the FDA, put it on hold right now. And so it is a difficult task, fixing and restoring these meniscus. It really is, because of all the factors. I've tried collagen meniscus implants. Okay, so this is based on a bovine collagen, right? Where I have a gap. Okay, you can see I have a gap and I measure it and I sew in, interpose. A little technical, but you sew it in and it just didn't work, right? The FDA actually pulled one of these off the market. Just didn't work. The human body is too powerful. Okay, so 5 months the scaffold fell apart. Here's the metal. I did 5-patient trial on something called an iforma. This is a shim, right? And I was cautiously optimistic, but they dislocated, right? Didn't work. I did 5 of them, 4 dislocated. And it's always on a Friday night, right about traffic time. I did plastic, okay? And I still have one patient. I did a big trial myself, and my PA were the largest principal investigator site in the world. It was a big trial. And the FDA, I don't think they quite understood it, but they denied it twice. So the company's regrouping, but this breaks. You get the human body is that powerful. And here it tries to recreate it. And they tear it and they dislocate. When they break and they dislocate. So this is a break, right? It's almost like a meniscus tear right here. And this is where all the force is. So, but it did preserve. I had some patients in it for 3-4 years. I had one patient, I used the Trump Compassionate Care Act, and I went back in, put one in 4 years later. So he's had 3 of them, and he still has it in. And so I was anticipating FDA approval, but it's not. The point is that, you got one real good trick, real good time to fix this. I want to just spend just the last couple of minutes here on meniscus root tears. You heard a lot about them. And the meniscus root tear is nothing more than a radial tear. It's just where the root is. So the meniscus, if you remember from my anatomy slides, you probably don't, but the meniscus insert, right, in the front and the back, right? And so when the root fails in the back, it's called a root tear. And a lot of the nerve endings are at the root level, so these hurt more. You know, I was getting out of my truck. I had a woman from Phoenix recently getting out of her truck, heard a pop, a lot of debilitating pain. So these, you know, these set up a flare. A lot of meniscus tears don't hurt, as you guys know. These can be very painful, right? You hear the root. So I tell people it's not like the meniscus tore. It's like it let go for a root tear. So it's like a flounder flopping around, right? And if you remember the first surgical slide I showed you was a root tear. I just cleaned it out and they went on to bone on bone. All right. And so, you know, it's amazing to me that still most orthopedic surgeons don't fix these. And it's just, you know, I think they're doing, they think it's the right thing, but, you know, it takes effort and a learning curve. I've done 500 root repairs. I'm not kidding you. You know, I've really taken upon a mission to do everything I can to protect the articular cartilage, right? So that includes ACL reconstruction or whatever, right? Restore the mechanics of the knee because you know where it's going to go. If you clean the root out, I mean, it's just an 80, you know, these people fail, right? So if you do the root and clean it out, yes, it's worse than an arthroscopy. You shouldn't have scoped it. I understand that. But these are the people that need a repair. So it's not just like, gee, scopes are bad. That is the, you know, that is the mantra that's out there, insurance companies included. You know, don't scope these, they do terrible. Well, you need to scope them and fix them. You know, because some, if you just like radial tears, if you just clean them up, see how you do, they're going to do lousy. Majority, really, right? You can get onto the path of mechanics of how these tear, but we fix these through capture it with a luggage tag type suture, and we put it through a drill hole in the bone. And I realize how many of these have been, you know, that have been staring at me that I've been not staring at it, right? And this is meniscus extrusion. Okay, what does the meniscus extrusion mean? Meniscus extrusions on these MRI reports, you may have heard of them, and then what it means is exactly it. Because on an MRI, you're not weight bearing, right? Here's the lateral meniscus, is this black structure, right? All type 1 collagen. That's centered, that's where it's supposed to be. This is all extruded. So you don't see a tear here in this particular shot, right? But it's got to be, it has to be torn, and I'm simplifying this, to be extruded. Okay, for the you know, I got an interesting case to show you. But this knee's going through a tough trouble, right? This is a woman who doesn't speak English. She's a cleaner, sport comp. I did her other knee, and she presented with this knee. And you know, hey, let's scope it. You know, and I know her very well. And like, no way, right? Her weight bearing X-rays aren't that bad, but I know this is in trouble. It's too far gone to go ahead and start fixing this, and I'm, you know, and that's debatable. But for the most part, when you see the bone light up like that, white, that means the knee's just giving up. This whole knee's going through a journey. One thing's for sure, you know, this type of patient just scoping to see how you do. I mean, one-way ticket to no good, right? And these are what you know, many of you see on the front lines. I shouldn't have scoped it, or I should go on your doctor, right? That's all because of that. It really is. So this is intact meniscus. This is extruded. So when it's extruded, you know, the meniscus is just not able to do its job because it left the knee. Okay. And here's a great example. I did this case recently. This is like 2 weeks ago, last week maybe. This MRI report was negative for no tear. Radiologist, and I called them, could not see a line, right? But it was extruded. Okay. This is my PA did a great job with this. So this is, you'll see this a lot. Hey, try cortisone and PT, Brian. Like, man, this isn't wildly extruded, right? Very symptomatic, by the way. This guy was very sore. Okay, but if it wasn't for him, he's like, you know, because you know, he's in charge, right? Hey, doc, I want to ride it out. I'm going to say no. But these are the patients that if you scope right away, I know it's counterintuitive, right? Because it's everything we're not hearing. Don't scope. It's a waste of time. You're making them worse. There are a subset of patients that, man, if you go right away, you're going to get a great result and they're going to have a good life, right? You know, I'm predicting, right? So, you know, this is not a big tear here, right? But it's dangerous because underneath it, it's got a radial component, right? Now, this part of the meniscus has very little blood supply. Okay, so I do something. I do a, you know, basically fix the belt of the pants. The zipper, you know, too much food at Thanksgiving and the meniscus was starting to extrude. So I put the belt back on, but got rid of the hangnail, right? This guy's going to do amazing. He's got very little arthritis, right? He's going to do amazing. So it's really down to the nuances of being this specific. And I just got a few more minutes. Hope I'm not talking too much. Yeah, I lost a couple of slides and I apologize here. You know, if you show me this video, you know, I think I did this surgery. I think I did this surgery in 17 or maybe 18. But in 2010, 9, you showed me this. I'd be like, what are you, crazy? Right? This is a degenerative tear. This guy's got chondrocalcinosis. Okay? This is medial, thigh bone, shin bone. All this fuzzy stuff is, quote, arthritis. Right? For these type of tears, you need arthritis. Arthritis is what causes it because the joint space is narrow. Now, he's not bone on bone, right? Not good. But, so then these guys walk and living his life, right? I think he was a third guy, if I'm not mistaken, but a little bit older, like the early 60s, mid 60s. So, this is go in there and clean it out. He's done, right? And this is like, oh, what are you doing, McKeon? That's a radial tear. You guys all see that? That's like a scissor. Someone took a scissor and snipped it. So the meniscus is dissociated. It went through all those collagen fibers. So the ability for that meniscus as a sponge to bounce back is gone. And really, it's not that. How much is torn? Very little. So when people go, how much you take out, doc? How much of my meniscus torn? I mean, it's way more. You need more information than that. So this guy did actually unbelievable. And I have enough follow-up on him. He's 7 years easily, right? And so, you put it home, pause the right? And the meniscus hard, that callus in a minute, but you know what? I'm glad I did it. All right, so this slide just shows the progression of an understanding of what it means for a meniscus to be gone or to leave or to be extruded. And this is a very common term you will see in MRI reports, and it's very confusing because an extrusion can happen with anything. It can happen with an ACL tear, it can happen with arthritis, it can happen with almost a normal meniscus at times. So it can be very confusing. So extrusion is just a description of the meniscus not being where it's supposed to be. And why it's not there, you got to figure out sometimes. And yes, it can be a tear, but it's not necessarily what we call a root tear every time. And that's what a lot of people think. But the end of the day is if you get an MRI that's non-weight bearing, okay, because in Europe they're doing these weight-bearing MRIs. It's kind of pretty cool. But on this MRI, you can see as they go through cuts, and the sagittal is on the left, and the coronal is on the front, where to the right, where the yellow slice indicator is, and you can see that medial meniscus is not where it's supposed to be. It's out of the joint, and it's torn at the level of the root. And this to the lower right is just another depiction of it. And then, but the most remarkable portion of this is that her x-rays are basically normal. And what's also important to understand is if you look at her x-rays in the upper right, her proximal tibia, her shin bone didn't develop all the way. And that's what happens in this subset of patients. And so you get hypoplasia of the medial side of the tibial plateau on the inside. So if it's a less surface area, okay, because it's supposed to be bigger, right? The inside of the knee should be bigger than the outside of the knee. And I apologize, I can't get the pointer to work, but at the end of the day, medial compartment should be larger than lateral compartment. It's not on these patients. Very common to realize that. So looking at everything, at the x-rays, weight-bearing views, MRI of all images is so critical to treat these patients and put the story together properly, as well as causation, because I know that's a big part of what you guys do, your responsibility to the world. So the lower left is an illustration of what we call a centralization, or what I call medial meniscus lift surgery. The lower portion of this diagram, that yellow meniscus, is out of the joint. And so just fixing the root, you've heard of medial meniscus root tears now, just fixing the root is not enough in a lot of patients because it's like sending a boy into a man's job, if you will. And so this slide shows me fixing the root in the upper left video. All right, but it wasn't enough. I need to get this meniscus centralized. And the MRI you just saw is this patient. All right, and I just did the surgery 2 weeks ago. All right, and so I'm drilling an anchor on the medial plateau you see in the upper right. And then finally, what you see at the very bottom is a final deal. Okay, I try to get some blood clot in there to help with, biological healing. But this is called the meniscus centralization. So it's a lot of work and a lot of effort. But if we just did a scope and clean things out to see how she did, this patient would do terrible. She has an unbelievable chance to do very, very well here. And I'm talking long term. And of course, you still have arthritis. You can see the end of the bone there, the wear and tear. That's what caused all this problem. Yes, it could be a twisting mechanism at work, missing a step, getting out of a chair, getting out of a car. Okay, but normally they're very trivial mechanism injury. This is not a meniscus tear that an athlete sustains, getting cut off mid-court, for instance, okay, or midfield. So it still could be a work-related injury, right? But you have to understand it's been brewing. It's just been brewing. And the instigator of all this is the weakening of the meniscal attachments because of the minor wear and tear. It doesn't have to be severe arthritis. It can just be a little bit because that increases the load on the meniscus because the articular cartilage isn't doing its job. Okay. And so the end of the day is, this video here not able to play, but basically this was way back when. This has been a lot of my career, right? This is a kid in high school, sophomore year. This was 14 years ago. He pulled off a piece of bone, so he had a meniscus root bony avulsion, and I didn't recognize that. I did, but I didn't. So I just cleaned it out and removed it. And it's funny. I always thought about that. It always bothered me because I knew the natural history of this young kid's knee was going to be a problem, and I wasn't ready to do a meniscus transplant. So here I start to gain my understanding. I'm on this personal journey, which all of us need to go on when we take care of patients. So we continue to look back at what we're doing and try to get better every day. But this video shows that I reconciled with his knee, 15, 12, 15 years later, something like that. And I able to reattach the meniscus. Didn't have the bone, but that's okay. And he's doing fantastic. So I really feel like I saved this knee, if you will. It's something as simple as that, because the meniscus was doing nothing. All right. So the idea is that, the meniscus, no doubt, is the most critical part of the knee. And we see these tears and pathology every single day of our lives for the most part. And, it really is the gold standard of the knee, much more than I originally thought with the articular cartilage. And, if you pay attention and, and really, pay attention to the minutiae and understanding and of the actual pathoanatomy, because everybody's different. You can actually get people that are thankful, and you can even make the papers sometimes. And so, with that, I really appreciate your time. And please feel free to reach out to me for any further questions. It's an exciting topic. It's hard to grasp and understand, but it's just the anatomy. It's fundamentals. And so thank you very much. And what a pleasure to be able to present to you today on this topic that I think is just so critical.
The questions. I invite you, for those who are remaining on the line, please use the Q&A function in your Zoom to submit a question, and then I will go ahead and read it to Dr. McKeon. But in the meantime, we did get one question, and it is, will a posterior horn root tear with extrusion respond to conservative treatment, or is surgery indicated?
And so that's great. Well, another question, of course, right? So for me, I believe, okay, now there's a lot of variables and factors. If they have no pain, let's say they have no pain. Hey, I tore it, I couldn't walk, I was in Hawaii, right, on a work travel. I'm a flight attendant. I slipped in a tub. That happened to me once, not me, and I come in and, geez, I'm way better now, doc. I mean, you don't do prophylactic surgery, right? But generally these are very sore, and you kind of know the natural history, it's not urgent, it's not emergent. I'll tell you, any pro athlete gets done that night, of course, right? That's different. But, you got to think biomechanics. Let's just say they have more slope than normal. They're more varus than normal. Like you start adding up in the other columns of things that are no good. Like some people need their posterior root much more than I do. When I did a root tear in the pandemic, it was a frontline guy. It was a doctor. And I'm like, man, look, you got a major slope to your shin bone. You can be a long recovery. And he's like, him and I started fighting the whole time. He pulled out his back, So, there is, it can be a longer recovery. It's not easy. But for me, all roots need to be really looked at and understood. And so, for me, most of them really should be fixed. I believe so.
Okay, thank you. Okay, we have another question that's come in, and it is, how is reimbursement from insurance? Does health insurance cover meniscus repair?
Yes, yes, they do. But they're really resistant and hesitant, and rightfully so. I mean, I believe we get what we deserve as doctors, right? We don't do enough time because it's hard, right? Enough time educating, and I reached out to Blue Cross Blue Shield myself in Massachusetts. Right, normally they hang up on me. I'm like, hey, I'm just calling friendly fire. I'm not complaining, and I want to sit down with them and educate them what meniscus really is and the effectiveness of repair. I believe if someone submits for a meniscus repair that's symptomatic, that should be a no-brainer because a lot of it is very time sensitive. I will tell you, this sounds radical, but if I have a patient, if I have a friend, let's say a friend of mine, right, and he goes, it only hurts me when I cross my knee, right, when I'm sitting down. And most people are like, well, blow it off. But let's say you had an MRI and it showed a radial tear, a small one. I would tell him to have that immediately. Now that's against everything we've learned. Give it 8 weeks, Colorado guidelines, we hear all this stuff. We don't look at it that way. Now that patient, by the way, doesn't need repair. They just need a meniscectomy. Because if you tear within the rim, if you tear within the inner side, that you get to it early, then you can get away with just a little quick meniscectomy, done, in and out, and you're literally going to save that person's knee. I think so.
Fantastic. We'll do one more question. This one is, this person references a meniscus surgery that happened a few years ago, and then the patient ended up with a vastus lateral tear and perineal tear. How is that possible?
Perineal tear. That's really unusual, right? Because those are extra articular. Those are not in the joint, right? Meniscus is mostly in the joint. Now, lateral meniscus is a little bit different, right? Because of the way we, grow up inside our moms. So the lateral side, like the lateral rift, right? There are other structures that if you use certain meniscus implants, we drive these needles in. So sometimes you can capture or trap a tendon if you don't pass it right. But within the joint itself, it won't be specifically a problem. But it could have been a result, which would be unusual, however. But I guess anything's possible. So but generally those aren't major issues. Generally,
okay.
This person it is, but
yeah, awesome. Well, we have a few more questions, but we want to honor people's time. So I will transition this to a thank you so much. This was a phenomenal presentation. I have seen chats about how amazing this topic was, that your energy was amazing, and this attendee loved the practical explanations with the videos. So thank you very much again, Dr. McKeon. For our remaining attendees, a playback of the webinar will be available within 48 to 72 hours. Additionally, when we do send out a link to where you can access the playback, we do encourage those who weren't able to scan the QR code to select the link for the webinar survey. And then if you did attend live, please anticipate your certificates of completion within 48 to 72 hours. Again, thank you everyone for your participation, and thank you, Dr. McKeon, for such an awesome presentation.
This is Cindy.
I had a blast.
Cindy won. I made it. It was good. It was so good. Thank you.
Please forward my email, by the way. If I didn't get to all the questions, that's my fault for hanging up by mistake. So
No.
please forward my email. I'm happy to anybody can reach out. We got to work together.
We will do that. Thank you.
All right. Thank you, everyone. Have a good afternoon.
Okay.
Okay,
all right.
great. Bye now.
Bye-bye.